Welcome back to your Pediatric Dentist channel Tiny the Talk. If you are new to this channel, subscribe the channel and for details of the channel, visit the bio section. Today we are covering conscious sedation part 1. While most kids can be calmed down with simple communication, basic behavior guidance, some situations require more advanced help to keep the child safe and treatment painless. For that, sedation techniques should be used. Starting with some definitions. First, conscious sedation. It is a minimally depressed level of consciousness that retain the patient's ability to independently and continuously maintain an airway and respond appropriately to physical stimulation or verbal command, and that is produced by pharmacological or non-pharmacological method or combination thereof. It is a minimally depressed level, means child might feel a bit floaty or drowsy, but they are still there. Then second is deep sedation. It is a drug induced depression of consciousness during which patients cannot be easily aroused but respond purposefully following repeated or painful stimulation, and the ability to independently maintain ventilatory function may be impaired, and patient may require assistance in maintaining a patent airway, and spontaneous ventilation may be inadequate. Cardiovascular function is usually maintained. So if conscious sedation is light nap where you can still talk, deep sedation is a very heavy sleep where you are right on the edge of general anesthesia. And in pediatric dentistry, this is a much higher risk zone because the child is no longer in full control of their body. So the patient cannot be easily aroused but respond purposefully following repeated or painful stimulation. So they will only react if the stimulus is repeated or painful, like a pinch or a dental injection. These shows the brain is significantly depressed. Spontaneous ventilation may be inadequate. So in deep sedation, the child might become too shallow or slow and they require assistance to perform the airway. So the dentist or anesthesiologist must be ready to perform a head tilt or chin lift to open the airway and use a plastic airway tube or a mask to push oxygen into the lungs. And cardiovascular function is usually maintained. So even though the breathing is struggling, the heart is usually still pumping fine on its own. However, if the breathing isn't fixed quickly, the heart will eventually struggle too. General anesthesia, it is a drug induced loss of consciousness. So in conscious sedation and deep sedation, there is a bit of consciousness, but in general anesthesia, there is a loss of consciousness during which the patients are not arousable even by the painful stimulation. The ability to independently maintain ventilatory function is impaired, so the patient often requires assistance in maintaining a patent airway, positive pressure ventilation. The tongue and throat muscles relax so much they completely block the airway. So for that require positive pressure ventilation. Because of depressed spontaneous ventilation or drug induced depression of neuromuscular functions, because their muscles and thought are relaxed, cardiovascular function may be impaired. The drug used for GA like propofol or sevoflurane can actually lower the blood pressure and slow the heart rate. So the cardiovascular function may be impaired, and these require constant monitoring by an anesthesiologist to keep the heart stable. Then minimal sedation. So a drug induced state which patient respond normally to verbal commands. Although cognitive function and coordination may be impaired, ventilatory and cardiovascular functions are unaffected. It is achieved via mild dose of drug like a low concentration of nitrous oxide or a single oral dose of sedative. They respond normally to the verbal command. They aren't groggy or confused, they are just less anxious. And cognitive function and coordination may be impaired, so the child might feel silly or a bit dizzy. They shouldn't try to walk unassisted or solve a math problem, but they know exactly where they are. So some cognitive functions or coordination may be impaired, and ventilatory and cardiovascular functions are unaffected because the medicine is so light that it does not slow down their breathing or change their heart rate at all. Now to perform the conscious sedation, the dentist or the practitioner must follow the clinical guidelines. So let's let's see the clinical guidelines for use of conscious sedation by dentists given by American Dental Association Reference Manual 2025-2026. So the first is patient evaluation and selection. Before any sedative is administered, the dentist must perform a comprehensive pre-sedation workup which include first medical history, review of all the medications, allergies if patient has, and prior anesthesia experience. Physical evaluation, documentation of baseline vitals like BP, heart rate, respiration should be monitored. Then ASA classification, it is American Society of Anesthesiology. So ADA guidelines generally permit ASA 1 healthy and ASA 2 mild systemic disease patients for in-office sedation, and ASA 3 or 4 which have a severe systemic disease patients often require a medical consultation or treatment in a hospital setting. Then NPO status or fasting. NPO is a Latin phrase which means nil per os. If this translates into English, it means nothing by mouth. So patient have to keep fast of 2 hour for clear liquids, 4 hour for breast milk, and 6 hour for non-human milk or light meals, which is standard for most oral and IV sedation. Then second is documentation. You have to document first informed consent form with a signature of guardian or parents of child. Then verbal or written instruction include objectives of the sedation, why are you going for the sedative agents and sedative techniques, and anticipated changes in behavior during and after the sedation. Special instruction shall be given to the adult responsible for infants and toddlers who will be transported home in a car seat regarding the need to carefully observe the child's head position so as to avoid the airway obstruction. A 24-hour telephone number for the practitioner or his or her associate. Then instructions that include limitations of activities and appropriate dietary precautions. Monitoring requirements. ADA requires specific equipment to be used continuously from the start of the sedation until the patient is ready for discharge. So for minimal sedation anxiolysis, monitor the patient's color of skin and mucosa and responsiveness. Continuously monitor the blood oxygen levels with the use of pulse oximetry machine. Then responsiveness, periodically check the patient can follow simple verbal command or not. Then for moderate sedation, pulse oximetry mandatory. Heart rate and BP documented at least every 5 minutes. Capnography now highly recommended or mandatory in many states for moderate sedation to monitor ventilation. It detects if patient stops breathing before their oxygen level drops. And precordial stethoscope used to listen to breath sounds directly. And when inhalation equipment is used, it must have a fail-safe system that is appropriately checked and calibrated. The equipment must also have either a functioning device that prohibits the delivery of less than 30% of oxygen, and an appropriate calibrated and functioning inline oxygen analyzer with audible alarm. An appropriate scavenging system must be available if gases other than oxygen or air are used. Then some personal requirements. So ADA 2% or 3% rules are central to safety. So the dentist must hold a valid sedation permit and be certified in advanced cardiac life support or pediatric advanced life support. Then assistant, at least one additional person trained in the basic life support must be in the room to assist the dentist and monitor the patient. Then recovery, a trained staff member must remain with the patient at all the time during the recovery phase. Then some preparations and setting up for the sedation procedure, and these SOAP-ME is the commonly used acronym useful in planning and preparation for procedure. So as for size appropriate suction catheters and functioning suction apparatus. Then O for oxygen, so an adequate oxygen supply and functioning flow meters or other device to be allowed its delivery. A for airway, so size appropriate airway equipment should be there. P for pharmacy, all the basic drugs needed to support life during an emergency including antagonist should be ready. M for monitors, functioning pulse oximeters and other monitors are appropriate appropriate like capnograph should be there, and E for special equipments or drug for particular case or emergency drugs. Then monitor during sedation. First is oxygenation. Color of mucosa, skin or blood must be evaluated continuously. Oxygen saturation is measured by pulse oximetry, which measure the amount of oxygen carried on hemoglobin in the arterial blood. It can measure multiple parameters like SpO2, perfusion, and heart rate. And its advantages are continuous monitoring, multiple sets of usage, non-invasive and user-friendly. Then ventilation. The dentist or appropriately trained individual must verify respirations continuously with the capnography. And circulation. Blood pressure and heart rate should be evaluated preoperatively, postoperatively, and intraoperatively as necessary, unless the patient is unable to tolerate such monitoring. Then recovery and discharge. So recovery safe requirements you have to have, which include backup gear like oxygen and suction. So even if you move the child to a quiet room or recovery chair, you must have oxygen and suction right there. If the child vomits or stop breathing during recovery, you cannot waste time running back to the operatory. Constant supervision. A trained staff member must be the eyes and ears. They don't just leave the child to slip it off. They watch the chest rise and fall until the dentist personally signs off on the discharge. Then instruction. Because the parents are often stressed, you must give them both verbal instruction and written instruction on what to do if the child stays sleepy or feels sick. Then the discharge checklist, the must-haves before leaving. The dentist used this specific criteria to ensure the child is safe to go home in a car. First, you have to check vitals. Stable vitals. The heart and breathing must be back to normal without any help of machines or spatial positioning. Then easily arousable. If the child is sleeping, they should wake up immediately when you call their name. They shouldn't be in a deep sleep anymore. Talking and sitting up. These are physical milestones. If a child can talk and sit up on their own, it proves their brain and muscles are no longer heavily depressed by the drugs. Back to baseline. The child should act like themselves again. If they were talkative before the appointment, they should be relatively talkative now. Hydration. The dentist checks the child isn't too dehydrated and can swallow water without choking. Coming to the instruction given to the parents during and after recovery and discharge. So first is immediate supervision. So constant eye contact. An adult must stay with the child for the remainder of the day. The child should not be left alone to slip it off in a bedroom. Car safety. During the drive home, second adult should ideally sit in the back seat with the child to ensure their head doesn't slump forward, which could block their airway. Activity restriction. No physical play, swimming, bike riding or climbing stairs for at least 12 to 24 hours because their coordination and judgment are still impaired. Regarding diet and hydration, start slow. Start with small sips of clear liquids like water, apple juice, Pedialyte to ensure they can swallow without vomiting. Then soft foods only. If they handle liquids well, move to the soft foods like yogurt. Avoid heavy, greasy or spicy meals for the first 6 to 8 hours. Numbness warning. If local anesthesia was used, the child's lips and tongue will be numb for 2 to 4 hours. Watch them closely to ensure they don't accidentally chew or bite their lip or cheek, which can cause severe swelling and sores. Then monitoring red flag. When to call the doctor. Parents should be told to seek emergency help or call the dentist immediately if they see first difficulty in breathing, snoring, gasping or bluish tint of the lip or fingernails. Severe vomiting. If the child cannot keep any liquids down for more than 4 hours. Excessive drowsiness. If the child cannot be easily woken up by calling their name or a gentle shake. Severe bleeding. If the surgical site in the month is bleeding heavily and won't stop with the pressure. Then pain management. Follow the schedule. Don't wait for the child to cry in pain. Use over-the-counter children's acetaminophen or ibuprofen as directed by the dentist and avoid aspirin unless specifically told otherwise. Avoid aspirin in child due to the risk of Ray's syndrome. Then emergency management. If a dentist intends for minimal sedation but the child stops responding to their name, the dentist must immediately stop the dental work. You must have the antidotes ready to go go, which include flumazenil, the reversal of the benzodiazepines. It kicks the sedative of the brain receptors to wake the child up. Naloxone, the reversal of opioids like fentanyl. It's restart breathing if it has slowed down too much. Then emergency kit must include the epinephrine for allergic reactions, albuterol for asthma or wheezing, and glucose for low blood sugar. The dentist is the person legally and ethically on the hook for everything in the room. This includes the facility ensuring the oxygen tanks are full and the suction is working. The staff ensuring every assistant knows their specific role in emergency. So person A calls emergency contact, person B gets the emergency kit. Diagnosis, being able to tell the difference between a child who is just really sleepy and a child who is having a laryngospasm or seizure. Then the rescue protocol everyone should use or follow, which is PABC. When a patient goes too deep or has an emergency, the dentist follow this specific scientific sequence. P is position. Place the child on their back with feet slightly elevated. Then second is airway. Perform the head tilt chin lift to open a throat. Then breathing. Give 100% oxygen. If they aren't breathing, use a bag valve mask, which is ambu bag, to breathe for them. And circulation. Check the pulse. If the heart is struggling, use emergency drugs like atropine or epinephrine. Then coming to the different sedative techniques. Inhalation sedation, which is the gold standard. This is the most recommended route. It has the fastest onset, which is 2 to 5 minutes, and the fastest recovery. The key advantage is it is titrable. Dentist can increase or decrease the dose second by second. Best for mildly to moderate anxious children who are cooperative enough to wear a nasal mask and breathe through their nose. Using a rubber dam prevents the child from mouth breathing and keeps the gas from leaking into the room. Then oral sedation, easiest route, accepted by almost all the children because it's just a drink or a pill. Risk is it is unpredictable. Metabolism varies by child, and once the drug is swallowed, you cannot take it back if the child reacts poorly. Primarily used for pre-medication to relax a child in a waiting room before IV or N2O starts, or for very fearful children who won't allow a mask or needle while fully awake. Then intramuscular sedation, it is a deep option, usually injected into the vastus lateralis in the small children to avoid the nerve damage in the gluteal region, and generally not recommended for routine dental care in 2026, and it is reserved for emergency stabilization or when a child with the severe special needs is combative or an IV cannot be started safely. Then submucosal sedation, intranasal is best. Giving midazolam via the atomizer spray in the nose is a very effective because the drug goes straight to the bloodstream bypassing the liver. So this is the intranasal mucosal atomization device, and excellent for pre-cooperative toddlers age 2 to 4 who need a quick onset of relaxation for a short procedure. Then intravenous sedation, the drug act in roughly 30 seconds. In children under 14, this should be done in a hospital or surgical center with an anesthesiologist, and it is best for adolescents with high anxiety or for those undergoing surgical procedure like wisdom tooth extraction. Then rectal sedation, this is the outdated route mostly used in some European countries but socially unacceptable in UK and USA, and clinical conditions only used in hospital settings for very young uncooperative children where other routes have failed. In next part we will cover nitrous oxide sedation. Till then, check out our weekly shorts, very important for revision, and new video on Sunday. If you want these or any other PDF, just like, share and subscribe the channel and comment your email ID with the topic name. We will share you the PDF. Thank you.